change. Dr. Amar has to go for another session. So we'll just start with imaging in strabismus surgery, and then we'll move on to the other topics.
Good afternoon, respected chair and all the colleagues here. So I'll be presenting imaging in strabismus surgery. I do not have any financial disclosures. So why imaging is essential? So it's basically for two indications. We want to understand the anatomical details, or we want some practical information which can be useful for surgeries. So for these reasons, we have few modalities which include CT scanner, MRI, or which can be considered orbital imaging, and there is one more section called local imaging, which includes anti-segment OCT and UBM. In clinics, we need imaging for these are the challenging situations where we need, that is resurgery, muscle slippage, ocular coat ectasia, or any other conditions. So in these cases, when you want to do CT scan or MRI, you'll be able to see the belly details, but you won't be able to tell where exactly muscle is inserting on the sclera. That's where the AIOS2025 comes into rescue, and of course the UBM is also there. UBM and AIOS2025 can be considered as a local imaging modality. So the uniqueness about these local imaging modalities is like they are cross-sectional imaging, and AIOS2025 is a non-contact one, UBM is a contact one. And in UBM you are going to get only one scan. By using AIOS2025 you can get 10 more scans or even 15 scans depending on how you are setting up the data. And these imaging will be done by the surgeon himself or herself, and they are cost effective. Unlike CT scan or MRI, they are very quick. So this is how we are going to image the extraocular muscles using AIOS2025. You can see here in the first image, with good abduction you can see the medial rectus muscle, with good adduction you can see the lateral rectus muscle, with good elevation you can see inferior rectus, and with good depression you can see the superior rectus muscle. So how to identify these muscles? See, these are the features we have described. So this is a lateral rectus muscle which we have captured. So we want to follow some of the fixed findings which can be replicated when you are identifying operated muscles. So this ocular coat is very well defined, it's convex, it doesn't have any surface bumpiness, it is not irregular, it's not having any scar. So ocular coat contour should be smooth. That is the first factor to identify it is an unoperated muscle. Second is, what is the depth of the hyporeflective layer? It is somewhere between 40 to 50% depth from the surface layer. So that's how the hyporeflective layer should be visible from the surface. If it is too deep, too superficial, probably that is not muscle. So intensity should be, it should be dark, but it should be having some internal noise because this is tendon. As you move posteriorly, that will be more dark because it's a pure belly. And the fourth factor should be, it should be continuous, because in some cases of operated eyes, you can see subconjunctival spaces which can confuse as a muscle, but whenever you want to define as a muscle, it should be continuously visible hyperreflective layer in an eye, and it should be around 40 to 50% depth from the surface layer. So how to scan this one? So whenever you are scanning, this is a Cassia machine, Cassia 2 short source anti-segment OCT. We should consider this plus safe configuration because it has a lengthwise and the widthwise scanning. So this is for medial rectus muscle, that is for lateral rectus muscle. This is again lengthwise, and this is the widthwise scanning. So this is how we are going to combine both the vertical and horizontal scanning. So this is the lengthwise, which is going to tell the insertion, and what is the longitudinal extension of the muscle. And this is a cross sectional. What is the width of the muscle? It could be 8 mm, 9 mm, 10 mm. This becomes useful in resurgeries. I will tell subsequently. So how can we differentiate what is the tendon, where is the belly? So this is Amar, again the 4 rectus muscle. As I said previously, the hyperreflective layer is going to have some internal noise which is tendon. Approximately you can say that probably belly has begun here, and this is more confident that this is belly. So the same thing applies to all the rectus muscles. So how much maximum muscle you can see? With good adduction you can see up to 9 mm of medial rectus muscle, up to 10 to 11 mm of lateral rectus muscle, and somewhere between 3 to 6 mm or 3 to 5 mm of superior rectus and inferior rectus muscle. So this is being said, we need to use this tool for some clinical purpose, and I want to tell one by one. So how to identify a recessed medial rectus muscle? So you saw the 4 criteria were there in the previous slides. So again we need to apply these 4 factors. If you see ocular coat contour, this is not smooth. There is a normal contour here, again sudden it is becoming thin here, that means muscle is missing. Hyperreflective layer, I won't see any muscle hyperreflective layer here, it is starting from here. Intensity, again it is initial portion. Continuity, I am seeing continues from here. So as we know anatomically, the sclera is going to be thinnest just before, just beneath the insertion. So this is the original insertion, muscle has been sent posteriorly. So that's how you are going to identify the recessed muscle. So again, this is the medial rectus muscle. You can see, as I said, ocular coat contour is disturbed, it is bumpy. So that indicates that probably it was an operated eye. That is the first factor. Hyperreflective layer, again, if you see, the ocular coat is thick. In the previous case it was thin, the muscle was sent back. Here probably the muscle is there, but it is quite thick. Why? Because tendon has been resected and it is a belly, and we can see hyperrefractive layer approximately 50% of continuously visible. So it is a resected muscle. This is the lateral rectus muscle. Again we are not able to see hyperreflective layer till here. So this is a probably original insertion and muscle has been sent back. This is a recessed lateral rectus muscle. So these are the side by side images of the one patient. You can see this is a right eye lateral rectus, that is a left eye lateral rectus. You can see all the 4 factors are satisfied here. We can see a continuously visible muscle, but again this is the original insertion and I am not seeing any muscle. Muscle is here. So if you measure from here till here, that is your amount of resection which has been done previously. So for lateral rectus resection, again the coat is becoming thick and you can see that there is no tendon here. It is a completely dark thick belly which is there in the original position. So this is again the resected lateral rectus muscle. Just compare with the left eye. You can see that that is a normal lateral rectus which has not been operated. This is the tendon which is less dark and the belly more dark. Here you can see this is more dark. So obviously this is a belly, tendon has been resected. So this is how we can identify which muscle has been operated or not. That is first thing, whether it's a resection or resection, and we can quantify the amount of resection as well. So this was first paper, because in Indian scenarios we lose patients' data frequently. So I tested it in patients with lost details. We don't know which surgery has been done previously, whether they had ESO or EXO, and we found that AIOS2025 is able to give the details, which could be 1 or 2 millimeter here and there, but getting information is important. Other clinical scenarios like muscle slippage, and of course this bleeding is because of preoperative FDD, force reduction testing. We did MRI, we can see that there is some orbital medial fracture, there is a discontinuity of the muscle, but I am not able to say where exactly the muscle is. I did OCT, you can see that it is quite superficial in the subconjunctival plane, and there is a muscle here which is around 11.4 mm, and I explored. We are able to see the ciliary vessel, and on post-op day 1 we have ortho or slight mild ESO, 4 prisms. So that's how we are going to influence, because by doing transposition of superrectus and infractus you won't be able to give the adduction, but by advancing and finding the MR you will be giving the functional, which is physiological ocular movement. So this is one more post-traumatic. You can see lid notching also. He has injured his infractus, so and there is a hypertropia here. So again the CT scan will not be able to, or the MRI will not be able to give where the muscle is on the sclera. He is lacking infraduction, which is very bad. So we did OCT, we can see the muscle here which is around 6.6 mm from the angle, and I placated and advanced the infractus muscle and I recessed the suprarectus muscle. At the end of 1 year he is maintaining orthophoria, and of course he has a lid notch which is not bothered. Most importantly, we give the introduction, that is very important. Post surgery, this is one more interesting case where, that's why I said we need to scan lengthwise and the widthwise. So if I scan the superior part, I can see the muscle is here, probably it was original insertion was here and it has been recessed. I can see here continuously, but here I am not able to see. And if I correlate intraoperatively, so approximately the muscle width corresponds to the corneal diameter, right? So only superior suture was intact and inferior suture got slipped. So that's how the inferior portion has slipped. That's why patient went for consecutive exo. And these are other conditions where, like in staphylomas, sensory exos will develop and patients demand cosmetic surgery in those cases. And we don't know whether the muscle is incasted within the staphylomatous area or it is quite posterior. In those cases, we found that it lies beneath the staphylomatous area and we don't need to puncture here, go through the pharyngeal route, recess the muscle whenever possible. And one more condition is like in one patient, somebody had a complication. This is operated SFL. You can see this is a haptic here, SFL haptic here, and MR is quite anterior here. So they were trying to do the MR plication, they injured the haptic, and IOL went into the vitreous. So in those cases also we can identify and trace the haptic, and we can just be cautious, right? So we don't want to injure the haptic. So to summarize, we can use AIOS2025 re-surgeries, traumatic and surgical muscle slippage, ocular cord ectasia, or in other clinical conditions where it is challenging to do the surgery. So this was the second surgery where I did 1104 muscles, including the normal and the operated. We published that one. The third one was purely dedicated to the slipped muscles, which we published. And there's something called multimodal because we want to combine both the image together. So this is one scenario. So patient had infractus injury in the right eye, the right eye hypertropia. This is the left eye control eye, and this is a CT scan. We do frequently, we don't do, but people in India frequently do CT scan as the first modality because it's a traumatic case. They don't go for MRI imaging because they are not looking for the muscle. In the left eye as a control, you can see this is a belly which has gradual transition as a tendon and it is getting inserted onto the sclera. It is not stretched. On the contrary, you can see the anterior tendon is stretched here and there is a bulging of the belly because probably muscle is cut here. So that's why it has gone posteriorly. So similarly, if you see in the coronal sections, so the anterior tendon is thin here, the contralateral, the other eye, infractus belly in the anterior portion is quite normal configuration. If you see posteriorly along the orbital apex here, you can see the corresponding belly bulging. So in those cases, again, you are not sure where the muscle is, but if you do OCT, you can see the muscle. So here what I am saying is, probably the rectus muscle tendon is torn here, that's why it is acting as a relaxing myotomy. The muscle has been pulled back, so that's why I am able to see on CT scan. But I won't be getting any insertion related because I need to open the conjunctiva here, I need to operate on this part, not on this part. So that's how you can use the CT scan, MRI plus AIOS2025 knowledge just to create a story. That's how you can identify. So this patient was operated, you can see this is a fibrotic area which is avascular, this is vascular area. We shape the muscle margin and we placated the muscle. So this is multimodal imaging where we want to combine CT scan, MRI findings along with AIOS2025 findings. Yes, ma'am. So these are limitations. When there is a scar, you won't be able to see, and it's again a evolving tool. So in strabismus subspecialty, we can use AIOS2025 for different conditions, including resurgery, muscle slippage, and other challenging scenarios. Thank you.
Thank you, Dr. Amar. Any quick question, because Dr. Amar will actually be leaving, so if there's a quick question we can take, or thank you.
Sir. Yes.
Yeah.
Are you able to do you bill the insurance or the patient for this, or how does it work with the billing?
So we work in a government hospital, where
Okay.
billing is not a major concern for us. So
Yes,
that is why. But I guess, I mean, if it's an investigation, just like you'll order an imaging, you would appropriately bill. But that's not something which we,
Yes, sir.
fortunately or otherwise, have to worry.
I work in a private institute, but most of our patients are uninsured, so they pay for it.